So the post-operative infection, it's as you asked, approximately 2/3 of all post-op cases endophthalmitis cases are post-operative endophthalmitis, and it is commonest after cataract surgery because that's the commonest operation that we do here. And intravitreal injections are the second most common probably, and they are given for various causes. So the incidence varies from 0.03% to 0.1% in different series. The incidence of endophthalmitis, though, has sharply declined over the past 50 years. It is still one of the most catastrophic complications of eye surgery. Symptoms and signs are blurred vision, sudden increase of pain. 25% of cases, they will start at 1 to 7 days after surgery. There will be lid edema, conjunctival chemosis, yellowish exudates in the cul-de-sac, corneal edema infiltrate, cells, flare, hypopyon in the antechamber, and you'll have exudates on either side of the IOL. So, when you try to look beyond that, you'll have cellular debris in the vitreous. If you could see them, retinal phlebitis is the first sign of endophthalmitis. Only a red reflex or a dark reflex may be visible, obscuring all the other details in few cases. There will be poor dilatation, media opacity makes the posterior segment assessment very, very difficult. So coming to the risk factors, the surgical risk factors are the most common for post-operative endophthalmitis. Let me talk slightly in detail about the wound abnormalities. Whenever you do a surgery, the cataract surgeons, they don't want to put a suture in their wound. It is very important. If you have not made a very good incision, the wound is not very good, it's better to suture. That's point one. So whenever there is a communication between the exterior and internal of the eye, so there are very high chances of endophthalmitis. So better to suture if you have not created a very good wound. Second thing, when you hydrate a wound, so if it is a larger wound, if it is a SICS wound, you should not keep the globe very tight. If it is very tight, there will be widening of the lips of the globe, the incision, and there could be iris prolapse. Even if the pupil looks round, there will be iris prolapse from that wound, and there will be communication from the exterior, leading to possibility of endophthalmitis in such cases. So you could keep the globe very tight in a smaller incision, suppose a phaco incision. But for SICS, where you make a scleral incision, larger incision, you should better put a suture there. So there were reports of corneal incisions have threefold increased rates of endophthalmitis, though not confirmed in the newer studies. It doesn't move. And other causes of increased incidence are when you have vitreous disturbance, but whenever you try to do a vitrectomy in the anterior chamber, from the anterior roof, usually it is not very complete. There will be some wick of the vitreous or something, they'll be entangled in the wound, and there will be communication from the exterior to the internal of the eye. These SFIOLs who have exteriorized haptics have a higher chance of having endophthalmitis. Use of braided sutures, contaminated solutions, IOL, donor cornea, etc. They are surgical risk factors. And these ocular examinations for bacterial blepharitis, MGD, nasolacrimal duct infection, obstruction, adnexal infections, they should be looked before the start of this surgery, not after having an endophthalmitis. And if the patient has active infection in the body anywhere, if patient is diabetic, he is immune compromised for any reason, there should be taken utmost care to keep the OT clean, everything asepsis care has to be taken. So these are bacterial endophthalmitis. The clinical features usually starts in 24 to 48 hours. There will be marked visual loss, pain, lid edema, conjunctival, as I said, conjunctival hyperemia and chemosis, increasing AC reaction, hypopyon. There won't be any red glow, and there will be rapid progression of signs. In fungal endophthalmitis, it will be usually delayed onset, mild symptoms, minimal discomfort, fibrinopurulent AC exudates, vitreous snowball exudates, vitreous abscess, and it is most commonly due to Candida albicans, Aspergillus fusarium. Long time back, we from Arvind Eye Hospital, we took data from all the endophthalmitis cases, and we found what Anita was also quoting, that Nocardia was very common in one of those studies. This was from Arvind Eye Hospital. Down south, people have a barefoot habit, and we found out that barefoot habit was a reason for Nocardia infections. The exogenous variant involves the anterior segment. So if you take a vitreous tap, usually negative cultures will be there. P. acnes It's an anaerobic gram-negative bacillus, normal commensals of the conjunctival sac. Equatorial white plaques is seen in the IOL, and it responds very well to steroids initially. And there will be exacerbation of inflammation when you do a YAG or you withdraw steroids. So another entity is sterile postop endophthalmitis, where you do not identify any organism there. Here symptoms are less intense, and these are because of intraocular drug uses, gas, etc., residual chemicals from sterilization, mechanical irritation of iris ciliary body by IOL, and excessive iris or vitreous manipulation may also lead to sterile postop endophthalmitis. And autoimmunity to lens cortical remnants can also cause sterile endophthalmitis, but it's very difficult to identify sometimes whether this is an exudate or a lens matter. So retained lens fragments and endophthalmitis may occur concurrently. Keep in mind, so suspect infection in any post-op ocular inflammation with retained lens material. This is another case of lymphoma where we were treating this patient for endophthalmitis, but finally responded to methotrexate. And if I have time, I can tell you a small story. This is a presentation to tell you that how to regain confidence after post-op endophthalmitis. We have a case, our friend, good friend, our next door neighbor's father-in-law came to us for surgery. We did a good surgery, and patient was very happy initially. On the first follow-up, when he comes, our colleague sees a thread in the wound, which was not connected to the anterior chamber. So he immediately took the patient to the OT and tried to remove that thread. It was very fine, very difficult to remove. In the process, there was some aqueous leak from that wound. Though the thread was also taken out, but there was aqueous leak. But it was hydrated and done, asepsis. It was done in the OT with proper asepsis. Next day, patient has severe pain, redness, and of course endophthalmitis. So everybody was jittery. We took the patient immediately to the OT, gave intravitreal injections, and he improved in 2 days' time. The redness, inflammation, lead edema, and all the hypopene, everything went away. But his pressure, intraocular pressure, rises very high, which was we were not able to control with all the medications. He had severe corneal edema, so visual restoration wasn't there. So and there was significant vitreous haze as well. The residual vitreous haze was also there. Despite medication, pressure was not coming down. We decided, okay, we'll do a vitrectomy, and if possible, we'll do a trabeculectomy at the same time. So we took the patient, we convinced ourselves and the patient at the same time, and we took this patient to the OT. We did a core vitrectomy, in fact, a full vitrectomy, and a trabeculectomy. Pressure came down, patient improved. Patient was very happy in the next follow-up. And he was very happy. His vision had improved significantly, and he was much more comfortable. But to me, when I took the intraocular pressure, it was on the higher side. So I asked him to massage the globe. Maybe that will keep the blood filtering and the pressure on the lower side. 15 days later, he comes back. That time again not able to see anything. He had an RD. So what to do? Very difficult. Again, counsel the patient, so you need another surgery. We took him to the OT. We did an RZ surgery with gas, because we did not want to do another surgery for removal of oil. So because of the gas, he was not able to see. After gas, the bleb failed, pressure rises again. Cornea becomes edematous. Very difficult to control again. Now with medications and everything, after the gas bubble has become smaller, pressure is coming down, but still the cornea is not very good, actually, one must say. And we are waiting for the cornea to clear. But ultimately, we may have to do some endothelial graft to this patient as well. So the lesson learned by this case was that early detection and timely intervention saves the eye. Yet one can have unforeseen complication, and one needs to be prepared for all those things which I told you. Visual recovery may be compromised following multiple procedures. Now my question is, to remove or not to remove the thread? Thank you.
Excellent presentation, Dr. Rajesh. I have few questions for you. You can answer from here also. One is for anterior segment surgeons, that is one tendency that it is toxic anterior segment syndrome. Seeing the early reactions in the eye after the phaco, and there will be some vitreous left also. So how do they can be cautious about that thing? The TAS and the endo.
TAS usually does not present like end of as we see. It will be corneal edema, not much of reaction and hypopenia. All the symptoms are also less. That is how you differentiate. But difficult. Sometimes it is very difficult. I take all these patients as endophthalmitis until proved otherwise.
And then the most important symptoms and signs, which you should, if I tell you to summarize, which you will put in order of severity, the symptoms and the signs.
See, the symptoms usually will not be very high because everybody is using steroids post-operatively, so not very marked symptoms one would see in such cases. You will have to rely on your clinical acumen, look for the signs, all other signs, like as I said, the edema, the chemosis, the AC reaction cells, hypopian, all those things have to be taken into account.
I think symptoms like the pain.
Usually
yeah.
they do not come with lot of pain
And the
lot of
decreased
redness.
vision.
Yeah, decreased vision is the first
These
and the
two
foremost.
I think you can tell to the patients while they are going home that if it occurs, you come very urgently.
See, to all my staff who answer the phone calls from patients, they have been told that before patient says anything, you should ask what is your vision.
Exactly. And
If they
about
say
the
vision theek hai or problem, then everybody relaxes and gives whatever advice is necessary.
And about the signs, I think the hypopene is one of the most important sign we should not take lightly. And then about the signs, the red glow and the RAPD. These three signs, I should say, it helps us to differentiate from the TAS, which usually gets confused with the end of lots of times, and there is delay in referring the patients.
I would like to add one point, for the task, the patient presents immediately next day, and there is a limbus to limbus maybe involvement. It is very unusual in endophthalmitis.
One more point in
Or
favor of
lid edema is the very ominous signs. If a patient comes with the lid edema, decreased vision, definitely going to have endophthalmitis kind of things.
See, the pain is a very important symptom. Initially, the intensity of pain varies according to patient, but worsening of pain is the ominous sign. If you have a worsening of pain, then you should always suspect endophthalmitis, because in TAS, this doesn't occur.
And one more thing I would like to add about TAS is, in a case of TAS, the retinochoroidal complex thickening is not noted, while in endophthalmitis, it is obviously there. So if you are confused between TAS and endophthalmitis, it is you can do a B scan and measure the RC complex. And otherwise also it's always better to be on the safer side and be more aggressive if you are confused between TAS and endophthalmitis.
I'll not take chances in my cases. I'll treat them as endophthalmitis.
Okay, so
Next